Hello and welcome to our lecture on Chapter 5. Chapter 5 is going to focus on ambulatory care services. Now those are services that are considered outpatient versus inpatient services. Now you might be familiar with some of these. They would include a physician's office, even an emergency department, community healthcare centers would be in there as well. Even urgent care centers would be considered outpatient or ambulatory services. We're also going to look at how these particular services fit in to the Affordable Care Act and the American Reinvestment and Recovery Act. All right, so with that, let's go ahead and get started with today's lecture. This week's word cloud is kind of bright. I used kind of a gold color on there. Do you know there's also a lot of studies that show that color helps with memory retention? So find a color that works for you, especially when you're studying for midterms, finals, exams, or what have you. And you will find that there's a connection that resonates with you as far as what color and helping you memorize. Yellow is pretty common for most people, and that is also why highlighters are often yellow as well. Now, remember, as always, with our word clouds and our words for this week, to highlight them in the text of the color of your choice, and do try to use them in your vocabulary to strengthen your proficiency in using those words, and make sure, of course, you look up the definitions as well, so you're using them correctly. When a patient is ambulatory, it means they're mobile or they can walk. An ambulatory healthcare center or facility diagnoses and treats patients who do not require an overnight stay. Many diagnostic tests and treatments do not need the patient to stay overnight. If the patient does need to stay overnight, it seems as though that trend tends to signal that something more complicated has happened with the patient. Patients can go home the same day for even many surgical procedures. Now, this was not the case even 10 years ago, where many procedures now that they send you home for, you stayed in the hospital for 1 or 2 days. The ability to offer outpatient care is a great time and money saver for both patients and the healthcare organization. In the 1980s, brought a new scheme to hospitals in the form of reimbursements. Diagnosis-related group payment system, or DRGs, came into practice. The difference the DRG brought to reimbursement is now the amount of money is reimbursed prospective rather than retrospective. It helps financial incentives for decreasing hospital stays and increasing the delivery of service. Hospitals responded with delivering ambulatory care in existing facilities and eventually creating even freestanding outpatient centers. These freestanding centers are often small and less expensive to operate than major hospitals. To me, this makes kind of a good sense of use of technology. The freestanding centers also brought healthcare to the patient's door right in their neighborhood by expanding the hospital's presence within the community. Now patients are saving time and money by decreasing their travel time to a centrally located facility or hospital. We'll discuss the different types of freestanding outpatient centers in just a couple of minutes. Were changing Medicare reimbursements and patient demands for convenient care the only factors for driving the expansion of ambulatory care? Well, the answer is no. The physician, too, also sees value in this as well. Many freestanding facilities are even physician-owned. Here, the physician is in control of their appointments and are not having to compete with other physicians in the booking of surgical suites. So now here is a break from the physician-hospital relationship. What was once a partnership has now become a competition in these cases. This means the physician is now shouldering all the costs if they decide to go it alone. Now, some physicians have formed groups to spread out the costs, while others have paired back with the hospital, forming a true fiscal partnership. With all the new construction underway for these wider array of services being offered at a lower cost, quality was becoming under scrutiny. The Patient Protection and Affordable Care Act, the ACA, along with the Patient-Centered Medical Homes, or PCMH, and the Accountable Care Organizations, the ACOs, emphasize population health, the roles of primary and specialty ambulatory services, and the prospective or retrospective reimbursement systems. Time will tell how all this will really pan out. It's all relatively new territory, and it could be up for amendments, especially with an upcoming presidential election. Your text points out an interesting statistic about doctor office visits. In 2009 or 2009, the National Center of Health Services estimated that patients made more than 1 billion visits to their doctor's offices. This included in this count were 586 million primary care physicians, more than 257 million medical specialists, and more than 193 million surgical specialists. That's a lot of billing going on. Also make note, all of this was happening before the Affordable Care Act. Now, how do you think the numbers will change in 2020 when we look back at our numbers that are happening between 2013 and 2016? Do you think the numbers will be higher, lower, or even unchanged? It'll be an interesting comparison. In the United States, the doctor's office has changed greatly since the 1800s. Physician groups have always been controversial. Physicians at the highly respected Mayo Clinic have a mixed response from other physicians. The American Medical Association opposed to group practices because they felt that group practice and salaried physician models calls ethics into questions. Well, how would that happen? Well, some had to do with private interests and the interest of not meeting the interest of the patient, as well as the motive behind patient care. With group health insurance, well, that put the topic in the foreground as the AMA expelled any physician associated with group health insurance. Remember how they were initially against the health insurance movement. For the next 30 years, it was an uphill struggle for physicians who wanted to be in a group or accept insurance to practice. Things changed in the 1960s with a shift moving from private to group practices. Medical specialties were expanding, and this was not a good fit for the solo physician. Technology was making advancements in leaps and bounds. Again, a model not so conducive to a solo practice. And then enter Medicare in 1966. This changed everything. And then another major game changer was malpractice insurance. Their costs began to dramatically rise. During the 1970s, the costs in other areas rose too due to very, very high inflation during that time period. The rising costs could be hard to bear when you're just going it alone as a physician. Banded together in groups, and the costs become lower. Beginning in a group also helped in understanding and utilizing technical advances that were being developed at a record pace, and also being able to afford that equipment, those technological advancements as well, especially computers. Fast forward to today, healthcare reform is reshaping the delivery of healthcare again. The physician is not the center of attention, now the patient is. Patient outcomes are the new driver of healthcare reimbursements. It has gone from service-focused now to outcome-focused, and how the outcome can be positive utilizing fewer services and effectively lowering costs. Well, that's the trick. The physician is now being graded on their performance as a healthcare provider by focusing on outcomes of populations they serve, not individual patients. This is also very new and different. Since the patient's health outcomes can be stretched over many providers, you got the primary, the specialist, the surgeon, the diagnostic, there needs to be effective coordination all along the way, keeping everyone on the same page. The ACA provides resources to support the development and testing of two service delivery models. We have the patient-centered medical home and the accountable care organizations. Let's take a look at the patient-centered medical home first. The diagram pretty well says it all. The patient is in the center, the receiver, or the focal point of the medical care. All the care revolves around the patient and their needs. The PCMH is made up of 7 principles. First, we have every patient has an ongoing relationship with a personal physician trained in first contact continuous care. The second one is the personal physician leads the team of individuals in the practice who take responsibility for the ongoing care of the patient. Then number 3 of the 7 principles, the personal physician is responsible for all of the patient's healthcare needs or takes responsibilities for the appropriate arranging of care with other qualified professionals. Those would be the specialists. The 4th component is care is coordinated and integrated across all elements of a very complex healthcare system and is facilitated by transferable electronic registries to ensure that the patient gets the care where and when they need it. 5 are quality and safety hallmarks. Physicians create care plans with their patient, engage in voluntary quality improvement activities, and use information technology to support optimal care. Patients actively engage in decision-making, and physicians seek feedback to ensure that the expectations are being met. And practices voluntarily obtain recognition by non-government entities to demonstrate the capabilities to provide patient-centered services consistent with the medical home model. 6, enhanced patient access includes open scheduling, expanded hours, and new options for communication between the practice staff and the patients. And then lastly, the 7th component is payment for services recognizes the added value provided to patients in the PCMH and includes reimbursements for time required by physicians and other team members for that face-to-face and other types of interactions with patients, care coordination, follow-up documentation, and responsibilities central to that kind of holistic care for every patient. This laundry list of principles is nothing new. It is new in how it is becoming the standard and tied to money or reimbursements. Now the question is adoption and sustainability. How are the reimbursements going to be given? How difficult will changes necessary for the implementation be for the physician and the medical practice? In 2006, we saw the first implementation of the PCMH. Based on that experience, it was clear it would be a long-term endeavor, including payment reform, role reassignments, new process implementation across many of the day-to-day practice activities, among other things. Now, this brings us to the Accountable Care Organization. This is a group of providers and suppliers of healthcare, health-related services, and others involved in patient care that work together to coordinate the care for patients they serve under the original Medicare program. Okay, that was a mouthful. In other words, it is exactly what you would think. It's a patient-centered medical homes that will be a primary component for the ACOs for the Medicare population. Each ACO must meet the following requirements. So we got 4 here. 1, they're a legally constituted entity within the state. 2, include healthcare providers, suppliers, and Medicare beneficiaries on its governing board. 3, take responsibility for at least 5,000 Medicare beneficiaries for a period of 3 years. And 4, meet Medicare established quality measures of care appropriateness, coordination, timeliness, and safety. In return, the Affordable Care Act provides a payment structure that combines fee-for-service payments with shared savings and bonuses linked with specific quality performance standards in the following areas. 1, patient and caregiver experience of care. 2, care coordination. 3, patient safety. 4, preventative health. And 5, at-risk population or frail elderly health. Now, as of 2013, there were 250 ACOs serving over 4 million Medicare beneficiaries. Take a look in this week's course news. I also have an interesting map showing the spread of ACOs across the country. As I promised you a few slides ago, we're going to go over some of the different types of freestanding facilities. These are non-hospital based, yet can be owned or financed by a hospital or healthcare organizations or even physicians. They can be independent, they can be for-profit, they can be not-for-profit. Some are single entities, while other are huge corporate chains. So let's go through some of them. Urgent care centers, or sometimes we call them doc-in-a-box. These are often on-demand medical care centers treating acute and chronic illness and injury. They operate on extended hours, and offer convenient care for illness or injury. The American Board of Urgent Care Medicine was established in 1997, offering certification to qualified candidates who have successfully completed an accreditation council for graduate medical education residency in emergency medicine, family practice, general surgery, internal medicine, obstetrics and gynecology, or pediatrics. Patients find urgent cares easy to utilize than more traditional ERs or ED departments. Many of us have worked in urgent care, especially starting off our healthcare careers, and find them a great training ground to kind of learn the profession and kind of get the frontline experience. Now, urgent care centers are not to be confused with a primary care physician, though. They are not used for that kind of continuous care. Again, they're for really treating the acute and chronic injury. Next, we have retail clinics. They are operated as well at retail sites like Walmart or Walgreens or Target, just to name a few. Some malls might even have a retail clinic in them. Retail clinics offer fast care, easy to diagnose acute conditions. They first opened around 2000 in the Minneapolis-St. Paul area grocery stores. In 10 years, by 2010, the number had jumped up to around 1,200 of these clinics. A staggering about 5.97 million visits have been reported in the year 2009. The big thing is convenience with these centers. Do you want to wait in hours at a doctor's office for a simple flu shot or an immunization? Probably not. Other advantages include lower costs, accepting insurance and co-pays, walk-in care. The reactions to the effectiveness of these retail clinics are mixed, but if growth is an indicator of patient satisfaction, it is definitely there and a trend that we are seeing. Okay, number 3 on our list of outpatient and ambulatory care centers is the ambulatory surgical center, also known as outpatient surgery centers. They account for almost 2/3 of all surgeries performed back in 2006. That's pretty astounding if you think about it. Now, your text has many statistics about them. The National Center for Health Statistics defines an ambulatory surgery center as a surgical and non-surgical procedures performed on an ambulatory or outpatient basis in a hospital or freestanding center's general operating rooms, dedicated ambulatory surgery rooms, and other specialized rooms such as endoscopy units and cardiac cath labs. Their creation was led right around 1970s in response to advanced technology and the frustration with hospital bureaucracy and the lack of available surgical suites. Remember when we talked about that a few slides ago? Hospitals, too, responded to the demand for outpatient centers in order to keep costs in line and allow more convenient patient scheduling. They are highly regulated, requiring special licensure, so that's a good thing. And the patient experience is better with fewer complications, faster recovery, and less disruption to their normal daily activity. And the last one I want to touch on is the Federally Qualified Community Health Center. These are primary centers, care centers that are set up originally in urban and rural areas where healthcare services are often scarce. Originally authorized by the Office of Economic Opportunity back in the 1960s, it was funded under the Public Health Service Act and drew from earlier models of public health service oriented to the needs of the underserved communities. The services offered are diverse and include many primary and preventative care, dental services, public assistance, Medicaid, WIC, and even lab and pharmacy services may be located in these one centralized areas within these in-need communities. Well, here we are again at the end of a lecture, and I want to thank you for joining me for this lecture. Make sure you watch the videos, study the terminology presented in your text, and I know you'll all do well on the quiz. And speaking of the quiz, remember this presentation is only meant to augment the material, not stand in place of it. You still need to read the book. I know many of you have questioned this in some of your weekly reflections. You know, do I need to read all this material? Well, yes, you do. And anyway, just remember, if you need help, just make sure you text me and let me know. All right, and so until next time, I want you all to have a great day, and thank you for watching.